Welcome to the EAU Podcast. In this special episode recorded at EAU 26 in London, we present Dr. Paolo Capogrosso and Dr. Marij Dinkelman-Smit discussing EAU guidelines updates on sexual and reproductive health. Join us as we embark on this informative journey.
Hello to everyone and welcome to this EAU podcast. Today we will talk about the sexual and reproductive health guidelines. I'm Dr. Paolo Capogrosso from the University of Varese and I'm the panel member of the Sexual and Reproductive Health Guidelines, and I'm here with my colleague.
Yes, good morning, Paolo. My name is Marij Dinkelman. I'm a urologist from the Erasmus Medical Center in Rotterdam, the Netherlands, and also panel member. And we're here to discuss our updates of this past year.
Exactly. So maybe we can start talking about how our guidelines are structured and how we did the updates this year.
Yeah. So we are with a big group, but it's also a large guideline with several main topics. So we have a section on male infertility that we updated the year before. We have a section on hypogonadism. We have sections on more sexual function related issues. So we always choose the topics that need to be updated and then divide ourselves in groups and in a systematic way try to collect evidence and see if that will change our recommendations for the year's update. And the last year we updated four sections. So hypogonadism, penile curvature, priapism, and ejaculation disorders. Yeah, and maybe it's good to start with one of those.
Exactly. Yes, we did huge work to update the penile curvature section because in the last years this was not done, and I think there were some changes, not for the surgical treatment of penile curvature and of Peyronie disease, of course, but mainly for the conservative treatment of Peyronie disease. As you know, we don't have so many novel drugs which are effective, but in the old guidelines, we still had recommendation for some drugs that are not even available anymore, and also for some compounds that have been proven to be ineffective. So we removed, for example, all the recommendations regarding antioxidant or pentoxifillin, all these drugs that have been proven in the last 2 decades that they are not effective. Then we removed the recommendation on the use of interferon alpha. Interferon alpha was a drug that was previously recommended as a treatment for intraplaque injection for Peyronie disease because there were a couple of randomized trials published several years ago which were positive, but actually this drug is no more available in Europe, neither in US, and also it is associated with some systemic side effects. So we decided to remove this recommendation. We still kept the recommendation on the use of collagenase, although collagenase is no more available in Europe, as you know, but still it is the most effective drugs. And we hope that novel drugs based on collagenase will come on the market in the next few years. And we introduced a novel recommendation on another compound, which is hyaluronic acid. So the literature regarding hyaluronic acid is not so strong for now. We have only randomized comparative non-placebo controlled trial and some retrospective series and prospective single-arm studies. So it is not level 2 or level 1 evidence, of course, but this is the main problem, as you know, with sexual medicine, that the level of evidence it's often not so high.
Yeah.
So we still decided to include a mild recommendation on the use of hyaluronic acid in the acute phase of the disease, because these data show us that these drugs can at least stop the progression of the disease. And in most cases, there could be a mild improvement of the curvature and of the penile deformity. So this is something that should be discussed with the patients. Side effects are basically zero. So this is a new option that we can offer to our patients.
Well, and I think this is very important for anyone who uses the guidelines. And we even have patients who look up the guidelines, that we really try to balance the information that's out there, the evidence collected, but also to rate the strength of our recommendations. So you might find recommendations that are weak, have a weak recommendation, but that is, I think, important for our audience to learn, that is how we structure and how we handle the paucity of good quality evidence. But we do like to give a balanced information on what is out there.
Yeah, exactly.
Yeah, and I think this is an important aspect. And maybe it's good to tell us a little bit more about the conservative treatment in penile curvature.
We had a discussion also on PRP, platelet-rich plasma. This is something that it is very well known and largely used over the world without strong data supporting this treatment. Even for Peyronie disease, we are still far from being able to provide a strong recommendation or even a mild recommendation. For now, we have only a crossover trial available, which shows some encouraging results, but is still not enough to suggest the injection of PRP to treat Peyronie disease. So for now, it still remain experimental. Researchers, urologists can use it in the context of a clinical trial, but we cannot suggest this use for clinical practice.
Yeah. So, and I think we agree that a very important aspect is identifying patients early. Conservative treatment, treat the erectile dysfunction, consider traction device or vacuum device, and good information about sexual activity that is actually healthy to remain a good normal fibroblast population in your penis. Yeah,
that still remain very important. So then we had also, I think, a nice update of the hypogonadism section.
Yeah.
And maybe we can talk about that also later.
Yeah. So hypogonadism or testosterone therapy is receiving a lot of attention always. But we really focused also on the contraindications and the difficulties if you have a prostate cancer patient. Our recommendations I think are now more clinically applicable because prostate cancer survivors may have very good quality of life improvement if they are treated with testosterone, if they are hypogonadal. So I think that is really nice in our update. And also we focus a lot on how to diagnose true hypogonadism. So functional hypogonadism versus organic hypogonadism. And our field as urologists is usually related to organic hypogonadism, where we say so primary testicular failure. So that is an important aspect, but functional or obesity related to hypogonadism is something that we see often. So we have given new updated recommendations and really would like to emphasize again, measure your testosterone twice. Really do that before 10 o'clock in the morning with your patient not having eaten. And also really know what kind of assay that you use, because the gold standard is an LCMS, but that is not widely available. And we know this from questionnaire studies of users. So you can use an immunoassay, but be aware of the reference values and be aware of the correlation with your gold standard assays. And that is important.
I think this aspect of diagnosis is very important, because most of the time in the office, we just look at the report of the lab without asking the patients when the test was done, if in the morning or in the afternoon, if it was in fasting state or not. We didn't care. We don't care about the type of test of methodology that has been used. So I think it is very important that we stress this aspect.
Well, and also for how you organize your care as a urologist, and if you work in men's health, that it's really important to know, where am I sending this patient to, which lab, and is the test validated? What is the reference value? How does it correlate to the gold standard? And I think that is our responsibility as urologists as well.
Of course.
Yeah.
And I think also we have to say that this year we did not still reach a clear recommendation on the use of testosterone in patients after prostate cancer treatment.
No, we do give some more guidance. So we say, well, if you are 1 year after your diagnosis and treatment and your testosterone is unmeasurable, then obviously it's okay. But the gray area is, and it's difficult. So what do we do with patients who've received radiotherapy, brachytherapy? And how can you really navigate your PSA levels and your oncological safety, but also try to accommodate your patient who can have severe complaints and quality of life issues related to low testosterone. So I think this is what we can recommend based on available evidence.
Yes, exactly. The available evidence is the problem again. As always in our panel. We lack strong data on prostate cancer survivors and hypogonadism. But still, this is what we can recommend to the people.
Well, and same holds true for the third topic that we updated. So the disorders of ejaculation. A very disturbing problem, and interestingly, also very variable geographically. And we really look for evidence regarding behavioral therapy, for instance, which can have a huge impact. But if we look at the available evidence, there's not that much there. So when we update the chapter, there's not really that much high-level evidence that can really influence our recommendations. On the other hand, we see that in the general offices, for instance, cryoablation of the dorsal penile nerve is performed in some countries quite a lot. But if we look at the quality of evidence, there's not very lost there. So that really, for us as a panel, but also I think for urologists, puts us in a difficult position. And I think that it's good for the readers and users of a guideline to consider that having treatments for something a patient asks of you might not be the best way to go, and that we could also try to really diagnose their problem better and make use of the information that the patient and partner have to really what problem do you want to solve.
Absolutely, yes. I think that the invasive surgical treatment for premature ejaculation, for now, they cannot be recommended to be used in clinical practice because data are not so strong for cryolisis and also for dorsal neurectomy.
I think it would be nice to just as for a final remark, have a brief update on the priapism. That's a chapter that we also updated. And I think that is something nice to discuss that for long we have always used an algorithm that's very clinically applicable. But we have seen that data showing, for instance, penoscrotal decompression has received more attention. And that is something that our users should be aware of.
Absolutely. Penoscrotal decompression is now recommended as a possible surgical treatment. Then we have, of course, all the conservative treatment before. And I think it will be very interesting for our readers to look at this new algorithm. So I think we are almost running out of time. It was a very nice talk regarding our guidelines. I hope that this could be useful to colleagues and also that this would be useful to improve patient care.
Well, it was been nice to talk to you, run this over, and I think a compliment for our chair and vice chair and the whole panel.
Of course.
For
congratulations to all our colleagues that collaborate to this great panel.
Yeah, great.
Thank you.
Okay.
Bye to everyone.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favorite podcast app. Until next time, keep learning and stay inspired.